Well, it's a great pleasure to be here. Actually, I was thinking, we were talking that this is a bit of a tribute to the liberal arts idea of how people should be trained. And I could be kind of a poster person for that in a way. I was an English major who got a PhD in psychology. I'm a card-carrying member of the American Statistical Association, and I've got a job now which is mainly designed, related to medical care. So I've wandered around a bit in terms of disciplines and things like that. And I'm going to tell you about a little journey that led to the formation of the foundation. And intriguingly enough, it started with the prostate. We held a focus group the other day with patients, as we do routinely, to talk to them about what their patient experiences are and things. And one of the things that the moderator came back to me and said is, if we're going to test information, we got to start way back further in terms of basic understanding of things and where you might think. And she said, for example, I think a good question to start off with is, who do you think has a prostate? Only boys, only girls, both boys and girls, or neither boys or girls? And the correct answer, by the way, is boys. But it's astounding. A lot of people get along really well without knowing anything about prostates for a while. And I didn't know anything about prostates for a good long while either. Urologists also then usually tell you that it's a gland about the size of a walnut, which is at the base of the bladder. And then people say, well, how big's a walnut? Because that's not necessarily universal information either. But the work that started the foundation really was about a condition called BPH. It's a benign condition that affects older men, and the prostate gets bigger, and it's sort of like a donut, and the hole gets smaller, and it gets harder to urinate. And there was an operation that was done really commonly, maybe in the late 80s. There were probably 300,000 or more a year being done, that sort of reams out the inside of the donut and makes it easier to urinate. But it's a quality of life treatment for the most part. I mean, the problem with it is it's inconvenient to get up at night or have to urinate frequently or have difficulty doing it. And so in mid-80s, no one had actually done a study. All the studies, and that was not so atypical of the research of that period. The studies of this quality of life treatment were all about asking doctors whether it was a success. And nobody had ever systematically asked patients, how they were before and after they got treated. And so, they were kind of making it up. So we did a project where we just systematically interviewed men before and after they had this operation. And we also had bought into, didn't buy in, I guess, the accepted model for how medical decisions get made was the doctor's job was to figure stuff out and make decisions, and the patient's job was to listen to what the result was and do what was needed to finish it up. And so what we thought was we were going to write rules. We were going to figure out which patients seemed to really benefit from the surgery, maybe which ones didn't benefit so much, and we'd write some rules for doctors so they could do a better job. And what came out of that research was it became crystal clear that that model wouldn't work. And the reason it wouldn't work is that the whole thing was dependent on how the patients felt about some things. And one is, how do they feel about these symptoms that the BPH caused? And it's a matter of getting up at night, and I say nothing. Some men told us that getting up twice a night was a real pain in the neck, and they would really be willing to undergo a significant intervention to fix it. Other men would get up 4 or 5 times a night and say, so what's the problem? I wouldn't want to do anything to fix that. And there's some side effects and effects of this procedure which are not trivial. And some men didn't find them troubling at all, and other men found them pretty troubling and really worth avoiding. And so it became clear that unless you had the input from the patients about how they reacted to the condition and its effect on them and the risks and benefits associated with the treatment, that you just couldn't make a thoughtful decision. And so the doctor couldn't make it all by himself. Somehow you had to get the patient involved. And the foundation really was founded on the kind of coming out of that work, where we said, how do we get the patients involved? And retraining all the doctors to be of a psychiatric mind seemed like an unlikely thing to do. And so we said, well, one of the things we could do to level the playing field and make a partnership a little more feasible is to get the patients informed up. And so that they had it, you don't have to teach them how to do the operation, but you have to teach them what the options are, what the pros and cons of the options are, and what the rationale might be for doing the different things that are available in an unbiased way. And so that's kind of what we set out to do. And what I'd like to do today is just take a bit of time, first to talk to you a little bit about why that particular decision is not atypical at all. In fact, it's very typical of the kinds of medical decisions that get made between doctors and patients. And then I'm going to tell you a little bit about how decisions are made now, and I'm going to tell you a little bit about why that's not the best way and maybe how we could make them a little bit better. So that's the game plan. And so I thought I'd start with three really common decisions. Herniated disc, PSA tests for prostate cancer, and taking a statin drug like Lipitor for cholesterol. These are three decisions that are made all the time. Back surgery is one of the most common interventions. PSA tests are something that 70% of men over 70 have had pretty recently, and Lipitor is everywhere. So why does this need to be a joint decision? Well, let's just start out with herniated discs. You probably know you get back and leg pain. It can really be a problem, and particularly if it interferes with the kind of work you do. If you do physical activity, it's important. It really is a huge problem if it's serious. And there's an operation that you can have that will relieve the symptoms about 80% of the time. So that sounds pretty good. So why wouldn't everybody want to have surgery as quickly as possible? Well, sometimes it makes you worse. It doesn't always work that way, though it, as I say, works that way more often than not. You know, you got to go through an operation, and some people would find it troubling to take several weeks off or more, to lose work. You have to go through a recuperation period. You got to do stuff like that. So it's not like it's getting a haircut. And for most people, it turns out your back will actually heal all by itself. And the symptoms in 2-3 years will be very similar whether you have surgery or not. And so what happens is surgery will get you there faster, and if things work out the way they're supposed to do it. So that's a good thing. But conservative management will usually work about as well. You get to skip the surgery and the recovery part, but it takes more time. And you've got to be able to live and work through and manage the pain for a while until you get where you get. So there's the framing. You know, we got two options, and this decision, I would argue, is not a medical option. The person who's got the life at stake is the patient, and they're the ones that got to decide whether they want to go through the surgery and get fixed faster and go through the recuperation, or not get fixed faster, live with it for a while, suck it up, manage their pain, but get there without going through the operation. And I would argue that the patient should have a big say in that decision. So now we'll do PSA testing. PSA is prostate-specific antigen. It shows up in the blood. If you have prostate cancer increases the amount of PSA in your blood. So that's one kind of indication that you might have prostate cancer. There are other things that cause PSA to rise, including just an enlarged prostate or some kind of inflammation. And about a third of those who have elevated quote-unquote PSAs actually end up having prostate cancer, and the way you get to find that out is a pretty unpleasant biopsy where you take samples of your prostate and take a look at them. About 3% of the U.S. men die of prostate cancer, and prostate cancer sort of seems to come in two forms. There's a fast-growing kind, which maybe is 10%. These are ballparks. And there's a slow-growing kind that doesn't grow very fast and never causes problems for people. And it's not really that clear that the treatment for either kind of these makes much difference, in that the fast-growing kind often just seems to be untreatable. And while you maybe can slow it down a little bit, it tends to be lethal. And the slow-growing kind may not need surgery. And in fact, over half the men that get to be 85, if you do an autopsy and biopsy their prostate, turn out to have prostate cancer, but a lot of them never knew it. So, should you treat prostate cancer early? You know, one trial found that men treated with surgery had about 5 in 100 better chance of being alive after 10 years than those who had no active treatment. So about 15 in 100 died of those who did not have surgery. About 10 in 100 died who had surgery. So what does that mean? Well, that means you would have improved your chances of being alive but by 5 in 100. But it actually means also that 95 of those 100 guys that got surgery didn't change their outcome at all. They ended up at exactly the same place. Some of them were dead from other causes. Most of them were alive and doing okay. So this is clearly one that does, and I'm sorry, and by the way, those who had surgery were much more likely to have lived those 10 years impotent and wearing pads to deal with their incontinence. So it's not like it was a free ride to pick up that extra 5 in 100 advantage. So should you have a PSA test? We've been taught that it's good to catch and treat cancer early. However, the survival benefit is, well, some people might think it was small and some people might think it was large. But it's finite. It's not like you do this and you live, you do this and you die. You get a little edge. There's a larger study of the rate of PSA testing on men over 65 were affected by cancer and found no effect. It turns out there was a natural experiment in Washington. They were very early to get enthusiastic about PSA testing, and they tested people at a very high rate. In Connecticut, there was not much uptake by the medical community, so they didn't do much PSA testing. And so they found a lot more prostate cancer in Washington, and they actually operated on twice as many people, or either operated or radiated twice as many people in Washington as they did in Connecticut. And lo and behold, after 10 years, there was no difference in prostate cancer deaths, which was not encouraging for how valuable it is to go do all that. The side effects of the treatment are great. So again, the argument I would make is that this is not a decision for a doctor to make for a patient, that they're trade-offs. There's a case to be made for PSA testing. There are people who would like to find it early, who would feel more comfortable if they knew what they had and then would treat it aggressively. And they should certainly do that. But on the other hand, that involves weighing some pros and cons that are pretty individualized and pretty special. And not having the patient have a big say in whether or not they have a PSA test seems to me, at least I think you could argue pretty strongly, that a patient should have a real say in whether or not he got a PSA test. Then I'll do statins. Statins reduce the level of bad cholesterols in the blood, and LDL levels have been linked to heart disease. And when a person with known heart disease reduces bad cholesterol with statin, about 1 in 25 per year will avoid a heart event or a death compared to those who are not on statins. So if you've got heart disease, I mean, you could argue about whether that's enough of a benefit, but over years it piles up. But anyway, that's about what happens if you don't have. But one of the things that happens, which is a pretty common thing in medicine, is that they take a treatment that is effective in a subgroup and then suggest maybe we could extend it out to more people. So if you don't have heart disease and you have elevated cholesterol to some level, statins will still improve what your cholesterol looks like. That is, your numbers will go down. But there's not much evidence that it does much for you, is the problem. And the best guess, I've seen different guesses, but probably about 1 in 250 per year will benefit from taking the statin, which means that 249 out of 250 won't benefit from taking the statin. And there are side effects. There's muscle pain. They cost money for somebody. Either it comes out of your pocket or some insurance company pays for it. And they add one more pill to take for the rest of your life. And as people get older, the pills add up. And so having another one is not necessarily what you'd want. So you might want to take one. It might make you feel better to have lower cholesterol numbers. Some people have been, feel like that's true. You might be the one in the 250 that benefits, and you never know for sure. And if that might feel great, but at least it seems I would like to argue that it would be good for you to understand what you were getting into, understand why you were taking the meds, and make a thoughtful, informed decision that this is something you wanted to do or it's not something you wanted to do. So that's where. So those are 3 examples, and as I would argue that there are just lots and lots, and a great chunk of the medical care that's delivered involves some kind of trade-off or something where it's reasonable to say that there's an input for patients' needs and concerns and values as part of the decision-making process. So decisions are made like this all the time. The University of Michigan, another Big Ten school you might have heard of, did a survey of about 3,000 adults 40 or over and talked to them about the medical decisions that they had made in the last 2 years. It turned out they averaged about 1 decision per year of a list of 10, which I'll show you in a second, regarding cancer screening, starting or stopping a med, or having an operation. And almost all the decisions, like the ones we just talked about, have trade-offs. So how are decisions like this made? And as I'll tell you what this means in a minute, but essentially, despite the fact that some people have said patients have gotten more proactive and more involved and partnershiping is more common, the main modal way that decisions get made are very paternalistic and directive. And essentially what you'll see is that doctors make recommendations and don't do much discussing and just get it done. And there's not much informing that's going on either. So the decisions we talked about, we looked at 4 surgeries: backs, knee replacement, hip replacement, cataracts, cancer screening, colon cancer screening, breast cancer, prostate cancer, and medications, high blood pressure, cholesterol, and depression. And so how are these decisions made? One of the things that, and this is all from the patient point of view, but the patient point of view matters. It might not be the same thing if you tape recorded the decisions. But the way that the patients walked away from the decision, the way they recalled the interaction was the following. First, we asked them, did your physician make a recommendation? And 75 to 85% of the time, the patients said they thought the doctor did make a recommendation. And that's cool. And so what did they recommend? Well, for the surgical decisions, about 65% of the recommendations were to do it. For the medications, about 90% of the recommendations were to do it. And for the cancer screenings, about 95% of the recommendations were to do it. And this is an average across all those clumps of things. And so essentially the conversation was that the doctor was saying, I think, I'm going to make a recommendation. And what I think is that you should do this, and particularly for the meds and for the cancer screening, which included PSA testing, by the way. And what role did the patients play? Well, one of the things we asked the patients was, did your doctor talk to you about what you wanted, what you thought would be a good thing? And essentially, for about half the time for the orthopedic surgery, they actually did. And that was the best. For cataracts, about a third of the time people thought the doctor had heard what they wanted. For the meds, about a third of the time they thought that the doctor had asked them what they wanted. And for the cancer screening, less than 20% of the time did they think that the doctor had talked to them about what they wanted. And what did the discussions look like? We asked people, so how much did you talk with your doctor about what the reasons why you might want to have the surgery, take the medication, do the cancer screening? The answers were a lot, some only a little, or not at all. So we just picked out a lot, but it doesn't matter where you pick it. The pattern is really the same. So what it says is, all right, for surgery, as I said, we had 4 different kinds of surgery, and there was a little bit of variation between the backs and the cataracts and the knees. But they said that the doctor talked a lot about why you should do it, from 49% to 68%, depending on which one it was. And on the cons, why you might not want to do it, or what the reasons were for why you might want to do something else, from 12 to 32% talked a lot about that. And then if you get down to cancer screening, you get 35 to 44% talked a lot about why you should do it, and 5 to 7% talked that much about not doing it. The point being here that there was much, much more discussion about why you should do things than the other side of it. It was not a balanced conversation. And the other problem, which you wouldn't be surprised at given the kind of conversations that were, is that the patients essentially knew nothing about these decisions, and that was really one of the most disappointing things. We had clinicians identify 4 or 5 things they thought that someone who was faced with one of these decisions, we had different ones for each of the 10. And then we asked people what they knew. And essentially, for 8 of the 10 decisions, no more than, a majority could answer no more than 1 of the 4 or 5 facts right. They didn't know that. So they were really highly uninformed. And so why does it work this way? Well, probably people here could answer some of that as well as I can. I mean, obviously the first thing is there's a tradition that this is the way doctors and patients interact. There's a history of delegating decisions to doctors. I've heard many doctors say that that's my job, and I take the responsibility. That's what they pay me for, and that's what I do. And they think that's right, and there are plenty of patients who think that's okay too. And so, but that is the model that has evolved over many years, and it's still alive and well in the U.S. today. 2 other things really help a lot, and that is, the second one is time. As most of you probably know, most doctors, particularly primary care doctors, say that they get 15 minutes a visit, and that by the time they get done with doing whatever they have to do. They really don't have time to talk about anything. And that's a common perception, and it seems to be a reality. And of course, a related thing is they essentially think they don't get paid for spending extra time talking to people. And so that's why it works that way. And so the question is, well, what's wrong with this model? It's worked for many years. And the first one, and is sort of where I started, is that I think it makes for worse decisions. I think decisions that serve patients' interests less well. And why decisions are worse? I think, as I said, there really are two components to a medical decision. And one part's the technical part, the part that the doctors went to the medical part of medical school for, to figure out, what's wrong with the patient, what the diagnosis is, to understand what the options are that are sensible options or different ways you could manage it that would be constructive, and to have good information about what the risks and the potential and the evidence about benefit or comparative effectiveness is for the things that are on the table. And I mean, that's what physicians for sure are going to know that patients are unlikely to know to start. And that role is absolutely critical. They also have some wisdom, and a lot of wisdom sometimes, from experience with other patients and how things have worked out for them and how they've accepted different things. And I think sharing that information is good, because often patients are in the position of being faced with potential downsides or risks that they've never experienced, and maybe they could use some help with understanding that. But on the other hand, there also is a distinctive set of pros and cons, needs and concerns that a patient brings that need to be into the equation if the decision is going to be good. We've got to know how to, one of the quintessential decisions that we do a lot with is breast cancer, because that one is so easy and so complicated at the same time, that the survival rate for most women, whether they have a mastectomy or a lumpectomy with radiation, is the same. So survival is, you can't make a decision based on survival. But obviously, from a woman's point of view, one of those you lose a breast and you have to deal with reconstruction, and the other you don't. The other one you actually have to deal with 6 weeks of radiation, and there's some things that go with that. There's a slightly higher rate of recurrence if you keep your breast than if you have more of it taken out. So those are things that are clearly just value issues. And I've talked to, I used to think everybody would want to be conservative, but I've talked to women who are very clear. They said, I just would feel more comfortable if I had the more radical operation and reduce my fear of this recurrence and coming back. I would feel more relieved, and it would be worth it to me. And I don't think that's an irrational decision, but I don't think that's a decision somebody else should make for a woman, because somebody else could look just like her and call it the other way. And so I think you've got to have, in order to get a good decision, I think you've got to get the weights and the concerns of the patients in there, if you don't have input from both. And these discussions, the way they're happening as they're described by the folks that in the survey, are not letting that happen. And why else is it a problem? Well, there are many people who argue it's unethical to have a patient undergo a test or a treatment unless they know enough to exercise an informed choice. I think that's a really plausible argument, that you shouldn't do things to people that involve their lives and consequences for them unless they understand what you're doing to them. And in fact, there are many people, I'm told, that have PSA tests who don't even know they're done because somebody checks off a box because they think that's routine medical care. I think there's really a problem with that. But I think the whole thing, that not involving patients and getting them informed enough to know what's going on has a real ethical issue. And the patient safety one's kind of fun. That my friend Jack Winberg makes this argument. Patient safety has a certain momentum these days, and a classic patient safety argument. You could start with the one, that the right knee is bad and they operate on the left knee. That's pretty bad. A worse one is if you're in a 2-bed room and the person in bed A is the one with a bad knee, and you operate on the person in bed B. That's called the wrong patient error, and that's not so great. But my friend Jack Winberg makes the argument that if you operate on somebody who, if they really understood what you're doing, wouldn't want that operation, you could argue that you're operating on the wrong patient as well. And that, and it's obviously tied in with the ethical argument. But but the notion that you're exposing people to risks and possible harms that they would not have accepted if they had understood what was happening and what the evidence showed, I think you can really say that that's not that one of the jobs of medical care should be matching up the right treatments with the right patients. And part of being the right patient should be somebody who understands and agrees that, yeah, this is a good idea. I'm willing to go through whatever this is. This makes sense for me. And I think there's a patient safety argument in there. And why else is it a problem? Well, I think it's a problem because people in the United States are routinely overtreated. I think it's fair to say. You folks are actually lucky if you are familiar with the variation in medical care costs, that Minneapolis is a model for most of us in the variation business in terms of cost-effective medical care. But the data show that, I mean, that folks in Miami, people on Medicare in Miami, we spend twice as much per person in Miami as we do in Minneapolis on medical care. And there's no evidence that things are any better as a result of that. There's no life-saving evidence. They're not more satisfied with their care. They have no sense of that they're, that when you interview people in Minneapolis, they have no higher rate of unmet needs or services that they want that they're not getting than they do in Miami. And the same, it's not just Minneapolis, Miami, it's also San Francisco is low and Los Angeles is high. And Tampa's comparatively low. There's all kinds of variation. There's just a lot of treatment that's not doing people any good. And we've got quite a bit of evidence about that, and we'd spend a lot of money on that. And as I'm going to tell you in a minute, I think if we got patients more involved and they knew what they were getting, that is another way to intervene in that process. So one of the solutions, one of the things the foundation does, and there are other people that are doing this too, is to produce what we call decision aids. And what is a decision aid? Well, they come in all kinds of modes. They're on the web. They come in audiovisual things like DVDs. They're in paper. They're even on audio tapes. But the common thing that they try to do, and there's some international standards for these things, is that they try to present all the options that a person has, and they try to present them in as fair and balanced a way as possible. They're updated with latest clinical evidence, and they include patient perspectives explaining why different options make sense to patients depending on what their values and concerns and goals are. And the difference between using a decision aid, which maybe lasts 30 minutes or so, and just having a conversation with a doctor the way we've talked about it, is, include a number of things about why it's good to start promoting the use of sources of information like that. One is the talk with the doctor is short, and decision aids are long. And I can tell you, having worked on making these, it's really hard to get all the information that somebody needs in less than 20 or 30 minutes, to tell you the truth. There's a lot that you need, even for what seems like a simple decision like a PSA test or colon cancer screening or something like that. It's complicated, and no wonder doctors don't have time to do it. Second, as we've seen, often doctors are persuading, whereas the decision aids are neutral or balanced. And it's not necessarily because doctors are so crazy about people taking statins, it's just efficient. And the most efficient way, sometimes there's some other kinds of interest too. I mean, there's certainly data that show that specialists have their own preferences for how they want to manage conditions that can be managed in more than one way. But mainly, I think that what we see is that doctors are in a mode of let's get through this and get the decision made. And I think decision aids present facts, and I think also that they're tested to be clear, and it's hard to ad-lib a clear message all the time. So I think there are a lot of reasons why they can be in advance. And there have been actually over 60 randomized trials of decision aids. And decision aids, what a randomized trial is, what they do typically is they take patients who are eligible for back surgery or going to have to be treated for breast cancer. They randomize them to whatever usual care looks like, or to being exposed to a decision aid of some sort. And then they measure how things are. And the data are just very consistent. The people who see decision aids know more. They make decisions that are more consistent with what they say they care about. And usually, but not always, they choose less aggressive interventions. The most striking one was a study was done in Toronto where they do less cardiac surgery in Canada than they do in the U.S. And they randomized people who were candidates for open heart surgery to seeing a decision aid or not. And there were 25% fewer bypass operations for the people that were informed than the folks who weren't, which is a pretty big deal. And why do they make less aggressive decisions? Well, probably at least three reasons. One, as I say, there's an awful lot of recommendations from doctors, and doctors really are very important sources for patients. Most of them say they're the most important source of information when they make decisions, and so when they have a preference, it's really highly effective in terms of turning the tide. So getting a balanced one that doesn't have a slant is probably helpful. The other thing is patients have to live with the consequences. The doctors don't. It depends a lot on which decision we're talking about, but for the surgeons, it's not uncommon for the surgeon never to see the patient again, and so they really don't know how it all turned out. And also, sometimes what we're talking about is interventions that have small benefits, and a small benefit may not mean as much to a patient as it might to a public health person or to a doctor. Obviously, decision aids are only part of the solution, and I would say they can come in all kinds of forms. We need to have systems that we can't ignore the fact that we've got to have a system somehow that gives patients somebody to talk to. They've got to have specific questions answered, and they have to if they have general information that's presented to them, that you also have to have someone who can help them relate it to their specific situation. So there are other changes. I mean, we've got to pay doctors to talk with patients. It's just silly not to do that. It just shows a crazy sense of priorities that we'll pay anything for a high-tech tool, and we won't pay won't pay a doctor to go talk to you. I mean, that's just misplaced priorities of the worst kind. And it's not just doesn't have to be doctors all the time. I mean, I think the increased use of support staff, whether it's nurses or physician's assistants or even health coaches that are kind of cropping up, that can be sources of information and support to people who have to make decisions is a really good idea. There's a really great program at the University of UC San Francisco where they have people who've been accepted to medical school and decide they want to take 1 year off between being undergraduates and going to med school. And they go out and they hire them as coaches for women who have breast cancer. And so what happens is that before the woman goes in to talk with a surgeon, she sits down with this about-to-be medical student, and they go through the things that are on her mind and what she cares about and the questions she wants to get answered, and they write them all down. And then this coach-type person goes into the doctor's office with the patient and makes sure that all those questions are answered by the doctor before they leave, and writes all the answers down, and then gives it to the patient when they leave. And so, that provides about three things at once in a very low-cost way. One, it helps the patient figure out what questions they want to ask. Two, it makes sure they get the answers. And three, we know that lots of people don't actually hear all the things that are said, particularly when they're in a time of crisis. And having this record of what happened can be a tremendous support. And, of course, health insurance doesn't pay for these people. They got a grant from a foundation to pay for that program because it's not part of medical care. And they're not paying these people a bunch. But that's such a simple addition to the kind of medical care that exists that can make a big difference, and I think would make a huge difference in the quality of decisions that are made. So, we do have to have people, but at least if decision aids were part of the solution, patients would have the basic facts and their options would have been explained, and given a core of information, no matter how the process goes, can improve the quality of the conversation with doctors, and we've shown that. So good medicine has at least two components. My friend Al Mully has this is one of his quotes, there's doing things right and there's doing the right thing. And doing things right is things like operating skillfully and not causing infections and washing your hands and getting the dosages right and getting all the sponges out and all those kinds of things. And so if you're going to do something, you do it in a way that's as beneficial and as least harmful as you can, and that's a really important thing. And we pay lots and lots for more technology, et cetera, to do more things. But there's also doing the right thing, which is the decision about whether you should be on the operating table or be getting this radiation or taking this pill in the first place. And that means matching the right treatment or the test or the med to the particular patient. And that's the part that we really, I think, neglect in the current medical environment. So doing the right thing means good decision making, and for that to happen, we have to set up procedures so that patients are routinely informed and involved in the decisions that affect their health and well-being. My goal is that it would become standard for medical care. We're in the process of trying to figure out what does good medical care look like. It also seems like it's a time for reform, and people are talking about different ways of setting standards and what would care look like and what should we expect of medical care if we're going to have it. And my goal would be that that no one would do anything to a patient until that patient, one, knew what the alternatives were, two, understood the pros and cons of those options, and three, was given a chance to discuss with the provider whether or not it was a good idea. I mean, that doesn't seem like a really high standard, but it would be a major change in the way medicine's practiced today, and I think it would be a lot better. Until then, uninformed decisions, I'm afraid, will continue to be the norm, and the medical care will cost more than it should, and will serve patients less well than it should, and that's too bad. Thank you very much. So if people had questions, I think that's what we are set up to spend the next few minutes for. So glad to elaborate.
Well, I have to comment
Yes.
that if Dr. Fuller were here, he would be very, very pleased.
Well, thank you very much. I'd be pleased too. Yes.
Did you have any experiencing resistance from the healthcare establishment in, rolling out decision aids or resistance to that being done?
Oh, absolutely. The question was, has there been resistance to the use of decision aids? And absolutely. I mean, it's not the norm in all kinds of ways. And actually, when the foundation was first started, we had hoped to. The idea was that we would that we would be able to sell them to providers, and then we could use the money to keep things updated and to make more and stuff like that. And that turned out to be a complete failure as a business model, because physicians don't have any money to spend like that, and they've got a whole lot of things to do. And that's actually the thing that we find more than, we actually are funding quite a few sites and actually there's one in Minnesota to try to get the use of decision aids into routine care. And it's a challenge because doctors have so many things that are on their list to do now for their performance standards. They complain about paperwork all the time, and they don't get paid extra for this sort of thing. So to add this notion of figuring out who needs a decision aid and getting it to them and then talking to them, I mean, that's not easy at all. And we are going to have to change the incentives. I don't think there's much... I think there's probably different opinions among physicians about whether this is a good idea or not, and about which kind of decisions it's appropriate or not. I think it's hard to argue in favor of ignorance, and relatively few people will say, no, I really think it's better if patients don't know what's going on. You don't hear that argument very much. But you do hear the argument that it's not that important. There are a lot of things we can make the decisions for them fine. And again, on the rank order of all the stuff I've got to worry about, this is not as high, not really high on my list. And so that's where the resistance comes from. Yeah. Others? Yes, sir.
Did you notice differences in this, or did you try to judge the kind of passive nature of the people or aggressive nature of the people and how they were making decisions as far as patients were concerned?
Oh, yeah.
There's some patients who are very passive. In fact, I would suggest that the majority of patients tend to be quite passive and sort of accepting of the guy in the white coat, which is what you're trying to get at, which is
Yeah.
a very good thing.
Yeah, no, the question was, are patients passive, and how do they really, to what extent is it their approach to the decision-making process that's responsible for the sort of lack of interaction? I think that's a really good question. There's no doubt they've been trained up to be passive, a bunch of them, and a lot of times, again, when we do tests with patients and show them decision aids and stuff and say, what do you think? One of the things they say is, well, I don't know if my doctor would really like me to come in with this kind of informed opinion. That's not the way we've been interacting. And I think there's some trepidation. We actually surveyed people specifically about their ideas and their goals, and it was intriguing how interested they said they were in being informed and involved, but particularly older people like me, said that we're more concerned about how it might affect the relationship with the physician and the interaction with them, which I think is something we need to do something about. But one of the things that does happen is that if a physician hands out a decision aid and says, or their office says, why don't you watch this and we'll go talk to the doctor, then it's changed the dynamics, because in a sense the doctor has said it's okay for you to be informed and it's okay to talk, and then I think that makes it different. And in those contexts, people are very positive about it. It feels kind of freeing to them. So, but there's several steps in order to get from here to where we need to get. You had your... Yeah, the internet has not changed things quite as much as you might like to think for the people that need it the most. One of the things that the Michigan study asked is where people got their information and whether they went on the internet for help. And it was kind of surprising it was 30% or something, but there were a big chunk of people who never got there. And as you know, while probably everything you would ever want to know is on the internet about almost anything, including how to do brain surgery, I imagine, it's really hard to get at in a way for most of us, unless you're really patient and you know where to look and you know how to sort the sources. So the internet offers great potential, but so far it's only a subset of the people that can get it, and even for those, it's not always easy to get the right information in a balanced way. There was a guy that did a study of websites, and I've forgotten which topic it was, but he was struck by even some of the legitimate ones don't present balanced kinds of presentations. I mean, the folks for some of the patient advocates ones, like the American Cancer Society, has some strong views that are probably more aggressive and not as balanced as some of us might like. And so it's really hard to know where to get the right information. So the internet has great potential, but we aren't there yet, and we need to augment it, I think, a lot. You had a question, comment?
I was going to say that I think your information is tremendous, and if I were still practicing, I would like to experiment with implementing it. But I think there's a basic philosophical question that you bring up here, and that is medicine a profession or is it a business? And I think that for some reason or other, and this has certainly been fostered through our society, for medicine to take on business methods and practices and that type of thing. And when you get to this last question of the doctor doesn't have the incentive and that type of thing to talk,
yep,
it's because of taking on these businesses methods of fractionating every procedure and such, deciding to pay or not pay for some.
Yeah.
And I think Bob Geist, for instance, here sitting in front of me with the surgeon, had it a lot better when they took a patient and said, for this operation it's going to cost $300-400.
There you go.
Nobody ever asked.
Nobody what?
Nobody asked the price.
Nobody asked a question?
Nobody asked the price.
Nobody asked him how much it was going to cost.
At any rate, they had that price, but they gave a complete service with that price. And I'm sure Bob included sitting down and talking to the patients and thinking of all these options as part of that price.
Yeah. I can't repeat, I was asked to repeat the question, but I certainly can't do justice to what you just said. I hope everybody could hear him. And there certainly are people who think that getting out of the paying physicians for each unit of service that they provide and getting back to essentially paying them by the patient or something and just do whatever it takes to take care of them is a better model. There have been some of the managed care groups, I think, gave capitated care a bad name, and I think someone's going to have to earn respect back for that approach. But the capitation means that you have X number of patients and you get paid so much per patient, and you do whatever it takes to make them that they need. And the good thing about that is that that if somebody needs to talk for a half an hour, then you talk to them a half an hour. If somebody only needs 5 minutes, you give them 5 minutes, and you tailor the services to what people need, and your remuneration's the same. And there are people who argue, as he did, that that's kind of puts doctors back into being more professionals and less car salesmen or something. But that's a controversial position, but I think we need to figure out. And a lot of people think we need to work on the reimbursement system, and that it's tightly tied to the way physicians feel about what they're doing and what they do. Yeah.
We were wondering about over-the-counter medications, like how usually patients sometimes the doctors about it, and sometimes the pharmacy.
I'm sorry. Could you project a little more?
Sorry. But over-the-counter medication.
Yep.
How can you make decision aids that can help in that case?
Yeah, I mean, there are limitless decisions. Actually, Consumers Union is working, and if any of you on trying to give at least information about meds, both about their costs and about what's known about their effectiveness. And one of the challenges is that particularly when you get down to the level of which med could you take, much less that you should be taking it at all. It's hard to cover them all. It's just a huge challenge, and it keeps changing because new things happen all the time. But I think, and some of it's going to be trial and error for over-the-counter medications, like which pain relief works best for you. But I think that I think what the kind of information that you can provide for people in this case doesn't have to be quite as elaborate, but just to be able to say that aspirin and Aleve and Tylenol for different people seem to work about the same, and you should probably go buy the cheapest one and see if it works for you, and if it doesn't, maybe you might want to switch, which is not a huge amount of decision need, I think, for a lot of these things. But one of the things that's really a challenge, which I guess is a tie-in, is that all the ads and the extent to which that distorts what people understand about medication, and that's certainly a challenge for those who want to inform patients as well. Did that address what you wanted? Okay. Anything else? Yes, ma'am.
Well, I'm interested specifically in your education methods. You talk about these decision aids. How are you disseminating them? How do you educate the general public about this subject? And then conversely, how are you educating physicians about this subject? Right? Do you have any outreach or educational efforts that make what you've just made to us public?
Yeah, we sure do try. Actually, we're working with the reason I'm here, probably in part, is Gary Schweitzer is part of the health journalism unit, and he's been working with us on something called Health News Review, which you might find. He came to us with a proposal for that, and we essentially evaluate a sample of news stories about health interventions, which has turned out to be quite successful. Essentially, they're rated. It's Health News Review, all one word. I think .org. It could be .net. I think, but if you Google it, it'll come out right. And actually, a sample, because the level of distortion of news stories about medical care just helps to undermine people's understanding of what they're getting into, and so essentially, and one of the things that happens is a lot of the news stories are hardly more than press releases from drug companies or device manufacturers, and then they get kind of reproduced with very little editing, and the standards that this team of reviewers apply include things like: did you cite who paid for the study? Did you get an opinion from somebody who was not being paid by the drug company that funded the study about what the value of this was? Did you present the statistics in absolute terms as well as relative terms? One of the real neat tricks is that if we've improved your outcomes from 1 in 1,000 to 2 in 1,000, that's 100% improvement in an outcome, but 1 in 1,000 is not something you'd want to pay a lot more for. And so So one of the things we've been trying to do is to work on that. We have been doing outreach with journalists too to try to get the stories better. And one of the most complicated stories that you all could work on helping with, if you could, is the possibility that more medical care might be better, and less medical care might be better, and more medical care is not always better. And that's an idea that is it's so prevalent in the news stories that anything anybody can say to do that might have some small benefit gets touted as something that we all ought to be doing. And people feel so much if they get less that it's because they're being rationed and abused and not getting something that's really of value, when in fact it may serve their interests a whole lot better. So we do work with journalists and hoping that they can do better. We talk to doctors when we can. And the decision aids, the ones we make, but there are a lot of people doing them. I'm definitely not up here trying to sell the foundation's decision aids, but they, they get distributed in different ways. Ours are distributed by a group that works mainly with employers and insurance companies, and some are available on the web, and some are available in other kinds of ways. But there's still a way to go. And just having a blockbuster, I think, doesn't do any good. I think they've got to be integrated with medical care. Yes, Dr. Magraw.
Pick up on the question that was asked about how do we educate patients, how do we educate the public, and I would make a distinction between patients and the public.
That's a good point.
One decides in the sort of objectivity of the classroom fades when the issue is directly involving you, like Dr. Johnson said, the prospect of hanging wonderfully concentrates the mind. I think we're kind of in a transition period, and I suspect it's going to take a long time. I've got to talk a little bit to make my point. In the time that I first got into medicine, if somebody in this group were walking out the door and fell and fractured an ankle, the call would go up for a doctor. Is there a doctor here? Now we call 911 or an ambulance or take them to the hospital. That really represents a signal difference in society, because the doctor in the old days was a repository of all that information. And nowadays we have a partially enlightened public, and it's getting more enlightened all the time. Really my question to you is, do you think there's much possibility in the current realities of American medicine for developing or for redeveloping a style of medical care in which the doctor talks to the patient? And I'm asking you.
Yeah, the question was, is there any hope that we can reintroduce into the U.S. medical care system a style of medicine where doctors actually talk to patients? And I think this is wrapped up, as you know, with people's concerns about the demise of primary care and the growth of specialties. And when you look at the choices that med students are making when they get out of medical school or in their internships, they seem to be going into specialty care at a much higher rate than historic patterns. And it's the primary care people, and I think it's because that we have a reimbursement system, in part at least, that pays better for specialty care and doing stuff to people. And there are a lot of people, as I'm sure you know, who've been working very hard to see if they can't reinvigorate the primary care model, because I think, and people are talking about things like the medical home, which is essentially giving primary care physicians comprehensive responsibility for people, including taking coordinating care, a coordinating role with specialty referrals, and not losing them off to the specialists. And we were talking earlier about losing them off into the hospitals where your doctor can't get at you anymore. And I think those are all part of having a physician who takes total responsibility or major responsibility for all your care. And I think that's part of talking. And you obviously have to deal with that. And is it going to change? Gosh, I don't know. I've got some friends who are working really hard at it. Sometimes people listen to us because they think, this is a tremendous opportunity, I think, right now. I think everyone's figured out that medicine doesn't make any sense the way it's being practiced right this minute. That it's costing way, way too much, and we're spending 16, 17% of our gross national product compared to anybody else. So Europe's maybe 9 or 10 or 11, or I don't know if there's anybody up to 12 at all, and they're doing it better. And so we're just doing a lot of things that don't make any sense, and we're not doing some key things like talking to people, making better decisions that make a lot of sense and we ought to be doing. So I think there are folks that understand that, and even some folks that might have a vote in high places, but who knows? There's so many forces in this world pushing in other directions, and there are a lot of people who don't want more discussion and better decision making. They like the way the decisions are being made right this minute, and so for the good guys and gals to win this battle, it'll be a struggle. But as I say, I get up every morning trying to win that one a little bit, and I do have some friends that are doing the same thing, and I'm glad to have some friends in Minnesota who are part of the battle, and that's terrific. Yes.
You were mentioning about how internet is not the best tool to do decisioning since it's difficult to get kind of like a neutral tool. What about referring patients to particular websites that you know have both like sites to it, just so that like do you use that as a website?
I'm sorry. Could you say that again?
Yeah.
Just the last.
Referring patients to particular websites that you know are neutral. And
Yeah.
Not all both sites.
Yeah. I'm sorry, you're saying, is it okay if you just refer patients to websites?
You were mentioning about how the internet is not the best tool to use for the decisioning.
Right.
It's difficult for patients to get the information.
Right.
What about referring patients to particular websites?
Yeah. I mean, I think people can do that, but doctors don't use it very much, as best we can tell. If they were interested in getting information to people, it can be done, and there are websites, and giving somebody a URL that would say, before you take your statin, why don't you go to the HealthWise website and read about the pros and cons of a statin, and then come back and we'll make a decision. I mean, that's a feasible thing for doctors to do, and they never do it yet. So there's going to have to be a change in standards. Somebody's going to have to decide that's what good medicine looks like. There's going to have to be some physician communication so that they actually know where a set of sites are or tools or something that they trust and that they really feel comfortable with. And we'll have to train, and we'll have to do some training of patients to do that. But that actually is a pretty easy part. If the doctors want it to happen, they can make it happen. We have lots of data that show that when the doctors say, why don't you get information this way, why don't we talk, the patients take pretty well to it, even though that's not what they expect. Anything else? Yes, sir.
When you're talking about the doctors telling them to do something, about 30 years ago with the seat belts, it turned out that the doctors told them to use the seat belts. It was the most effective way of introducing seat belts for children. Yeah.
Doctors have when you ask patients who's the most important source of information, even though it's not the way that they're all practicing, doctors are still number one. I mean, particularly primary care doctors, and that's where people, and even when they say, well, I don't get to talk to them too much, but that's where I would go if I needed help. So that model is still there, and the power of a physician to affect things is terrific, and we just need to kind of harness and direct it a little bit more. Eva, have we done it? Okay. Well, again, thank you very much.